that is reflecting in our practice, which is the errors of refraction. So we have been studying all these long weeks of optics in order to apply these principles in our practice, in our studying how can we use the optics in correction of refractive error of a patient. So what is an error of refraction? Or before starting the errors of refraction, we need to know some basic principles again and again. First of all, we have different axes and angles related to the eye that control the vision and control that control the relation between the eye and the object of interest. First of all, we have the optical axis. If we have an eye here, and this is the temporal side, so this is temporal, and this is nasal, we have first what is called an optical axis. The optical axis is that a line that is passing through the center of the cornea and the center of the lens and pass also with the nodal point. So any line that passes within the nodal point will pass undeviated, as we know. So if this line is passing also within the center of the cornea, then this is called the optical axis. However, this optical axis doesn't coincide with the visual axis because the center of vision, or the fovea, is not on the center of the posterior curvature of the eye, because the center of the vision, or the fovea, or the posterior pole, is slightly temporal. So hence that we have what's called the visual axis. In the visual axis, this is the line that passes through the object of interest and the nodal point and the fovea. This line is called the visual axis. Again, visual axis is the axis that connects the optic or the object of interest to the nodal point, to the fovea. So what is the nodal point? It is the point which is located near the posterior surface of the lens. This is the point of intersection between the visual axis and optical axis, and any light passing through this nodal point will pass undeviated. We have another axis that is called the fixation axis. This fixation axis is the axis that connects the object of interest and the center of rotation of the globe. You remember when we were talking about the fixed principles when we were discussing the extraocular muscles, we said that there are different fixed principles, or X and Y and Z principles, that are present at the center of rotation on the eye, and these principles allow the globe to rotate medially and or nasal and temporal, up and down, and intorsion and extorsion. These all rotation are centered over a center of rotations, which is present at the center of the globe, which is present at the equator. We can say that it is the center or intersection between the optical axis and the equator. So this is the center of rotation. When we have a line that passes through the center of rotation and the object of interest, then this is called a fixation axis. Finally, we have the central pupillary line. The line that passes through the center of the pupil and the center of the cornea, or the center of the cornea, center of the pupil, and perpendicular to the cornea, then this is called the central pupillary line. So from its name, central pupillary line, so it is on the center of the pupil. So does this mean that should it be center on the cornea as well? And the answer is yes, but it should be also perpendicular to the cornea. So if we have a line that passing is central to the cornea and central to the pupil, then this is called the pupillary line. But does this line pass through the nodal point? The answer is no. So because that we have mentioned before that the cornea and the pupil, the center of the pupil and the center of the cornea is slightly shifted from the nodal point. They are not on the same axis. So if we have again a line that is perpendicular to the cornea and center to it, and passing through the center of the pupil, it will be called the central pupillary line. So why we are studying these lines? Because there are some relations between these lines. So we have the visual axis and the optical axis, the fixation axis, and the central pupillary line. The angle between the visual axis and the optical axis, it is called the angle alpha. Angle alpha. Angle alpha, it is the angle between the visual axis and the optical axis. While the angle between the optical axis and the fixation axis, it's called angle gamma. And finally, we have the angle between the visual axis and the central pupillary line, which is called angle kappa. Again, this is very common to be asked in the exam. What are the different axes and what are the different angles and what are they made from? So let's have more details about these angles. So angle alpha, this is the angle between the optical axis and the visual axis. It is present at the nodal point. So again, the angle between the optical axis and the visual axis, it is called the angle alpha. So this angle, normally it is about 5 degrees. In case angle increase 5 degrees, and then it is called a positive angle alpha. If it is in myopia, it will be decrease more to less than 5 degrees and even become negative. So this occurs in myopia. And why does this occur? So if we consider that this middle circle or this middle eye is the emmetropic eye or the normal sized eye, and this is the fovea of the emmetropic eye. So this will be the visual axis, and the optical axis will be the same here, which it will be the passing over the center of the cornea and the center of the lens. So in case here of the emmetropia, if the eye is more short or more hypermetropic, the fovea is more temporally displaced. So this will be leading to increasing the visual axis or the more nasal displacement of the visual axis. So this will lead to increasing the angle between the optical axis and the visual axis in case of hypermetropia. However, if the eye is more myope or more large, this will lead to less displacement of the fovea. So the fovea will be more close to the optical axis. So this will lead to decreasing the angle between the optical axis and the visual axis, and even can become negative. So if it is negative, it will lead to what's called apparent convergent squint. So the eye appear as if it is converging because of this negative angle alpha. Now we have the visual angle. The visual angle, it is the angle between the optical axis and the visual axis again. But is it the same like the angle alpha? The answer is no. Because in the visual angle, it is the angle between the extremities of the object. So it is not from the object itself, but it is from both ends of the object. And it's also located at the nodal point. So it is the angle subtended at the nodal point made by the both ends of the visual both ends or both extremities of the object. And this is the principle of the visual acuity testing. So when we are seeing this visual acuity chart and we want to know what is the visual acuity of a patient, this is by this central hole within the optotype of the visual acuity chart. This should be the both extremities of the visual angle. So one of these extremities will be at the optical axis and the other will be at the visual axis. So this will be the actual angle located at the nodal point. The smaller the angle, the more the smaller the size, the more visual acuity, because this is the maximum angle that the patient can see. So this will be discussed in the physiology of the visual acuity, but just to let you know now that the visual angle is the principle of the visual acuity testing, and this visual angle, it is the distance between the both extremities of the object subtended at the nodal point. Angle gamma doesn't have much application, which is the angle between the optical axis and the fixation axis. As we can see here, this will be the angle gamma, while the one of the most important angles, which will be the angle kappa. So what is angle kappa? Angle kappa, it is the angle between the central pupillary line, as you can see here, and the visual axis. So the central pupillary line, which is perpendicular over the cornea, passing through the center of the cornea and the center of the lens, and the visual axis passing through the object of interest, the nodal point, and the fovea. The angle between both lines will be the angle kappa. The importance of this angle is that it is the angle between the visual axis and the anatomical axis. So the anatomical axis is the central pupillary line. And also that this angle is the only angle that can be measured clinically. It can be measured by either a device called the synoptophore or arc perimeter, and it is slightly less than angle alpha and angle gamma. And if it is myopters, it will lead to apparent exotropia. So let's see in this example. If we have here a temporal and we have here a nasal, so the visual axis is the axis passing through the object of interest and the nodal point and the fovea. So it will be the red line. While the central pupillary line will passing perpendicular over the cornea and central to the cornea and central to the pupil. So the angle between both will be called angle kappa. So if this angle is large, what will this mean? This means that the eye is deviated more temporally. So the eye is more exotropic, as you can see here. If the eye is more exotropic or more deviated temporally, this will lead to increasing of the angle kappa. So and the clinical application as well, that in case of we are projecting a central pupillary light reflex over the cornea, we can notice that the central line or the central light reflex is not on the center of the pupil, but it is slightly nasal. And why does this occur? Because while the patient is fixing on this central light, the eye is not on the central position. The eye is slightly deviated temporally in order to place the fovea over the, or to place the point of fixation over the fovea. So the eye is slightly deviated temporally. That's why the pupillary light reflex appears slightly deviated nasal. So if you project the light reflex over the cornea, over a patient, and you can see that the light reflex is slightly deviated about 4 to 5 degrees nasally, then this doesn't mean that the patient has a squint, or this doesn't mean that the patient has a divergent squint. But this is acceptable because of angle kappa. I hope that this concept is clear to you, because the visual axis here doesn't coincide with the anatomical axis. Okay, so let's start with, let's begin our journey with the refractive errors of the eye. So in order to know what is abnormal, we need to know what is normal. So what is normal is a measure of emetropia. Emetropia meaning that the eye that has no refractive error, meaning that it is a refractive condition in which the incident parallel light rays, I just tend to forget to use the pen. Okay. So we have here incident parallel light rays over the eye. If we have, or the emetropia, meaning that if we have incident parallel light rays falling over the eye, these parallel light rays will come to a focus that is present in a retina. And this is provided that the accommodation, which is here by the lens, is at rest. So the eye is not exerting any accommodation. Again, if the eye is not exerting any accommodation and there are some parallel rays that are falling over the eye, they will come to a focus on the retina, making a sharp image. So this means that this patient doesn't have any refractive error. And this is what is meant by emetropia. So what is the pathological conditions or what's abnormal? The first refractive error is called myopia. Myopia meaning that it is a refractive condition in which the incident parallel rays does not fall into a focus into the retina, but they form a focus in front of the retina, while again the accommodation is at rest. So this means that once they make a focus in front of the retina, the light rays the light rays will make a focus and then they will continue their way, making an image size over the retina that is large and blurred. So this is one of the refractive error in which that we don't have a clear image over the retina because the image is formed in front of the retina. So here we can have some examples of the patients with myopia. So we have here the nearsighted eye in which the light rays, parallel light rays come from an object, making an image in front of the retina. So we have here now see a blurred image, as we can see here, and again. So the normal eye will form a focus onto the retina, but the myopic eye will form a focus in front of the retina. So what are the causes of myopia? We have two different types of myopia. So what will make the eye doesn't refract the light rays on the retina? This can be either that the eye is too big, which is called the axial myopia, so that the light rays instead of refracting in the retina and the eye is big, so it will be refracted inside the vitreous. Or the eye is more powerful, so it has more refractive power. And this refractive power can be either due to curvature, so there will be increased curvature of the refracting surface of the eye, such as the cornea. So increasing refractive power of the cornea will lead to curvature myopia, or even increasing the curvature of the lens, as in cases of lenticonus, will cause curvatural myopia, or index myopia. Index myopia meaning that it is caused by changing of the refractive index. So increasing refractive index of the lens, for example, the lens will cause increasing the refractive index of the eye, or if there is decreasing the refractive index of the cortex of the lens, this will lead to also increasing the index myopia because it acts as a minus lens, as we will see later on. So again, myopia can be either due to increasing the length of the eye, as in axial myopia, or increasing the power of the eye, or in refractive myopia. The refractive can be either due to increasing the curvature, so it can be more curved, like in keratoconus or lenticonus. So the refracting power or refracting surfaces of the eye assume more curved shape, or it is due to increasing the refractive index of the refracting surfaces of the eye. So for the axial myopia, here we have the parallel rays that should have passed or should have made a focus on the retina. However, in case of the axial myopia, the eye increase in size so that the eye or the focus will not be present on the retina, but it will be present in front of the retina, making a blurred image over the retina. So is there any relation between the axial myopia and the change in the refracting power of the eye? The answer is yes, because every 1 millimeter change or increase in the length of the eye will cause increase of the dioptric power of the eye about 3 diopters. So this is very important in measuring the intraocular lens power for biometry before the cataract surgery. We need to know that we should measure the axial length accurately, because if it is increased or if it is decreased, it will change the refracting power of the intraocular lens dramatically. We have different types of the axial myopia. So we have the simple, we have the congenital type that starts from the birth. So we know that during after birth the eye is hypermetropic. We are born with a very small eye, and if we have born with large eye, or if a patient is born with large eye, then this is called an axial myopia, congenital axial myopia, that starts at birth and usually reach about -10 diopters and can be associated with degenerative changes. While simple myopia starts at the puberty with the grossest part of the body and usually stops at 25 years old and usually doesn't exceed -6 diopters, and it is not associated with degenerative changes. There is another serious form, which is a more visually impairing form, which is called degenerative type. And this type starts at the childhood and usually stops at 35 years old, and it reaches massive amount of diopteric power up to even -30 diopters, and I have even seen a case of -35 diopters, and it is associated with a massive degenerative changes that will affect the vision. So what will be the complaints of a patient who has myopia? The patient will report that he has a distant blurred vision. So these patients will see the near-sighted objects very clearly. However, they will have a problem with seeing the distant images. So they would tend to small or to decrease the palpebral fissure height of their eyes in order to form a pinhole effect. So we said before that the pinhole effect will allow only the axial rays to enter the eye, leading to only seeing the central visual field, leading to increasing the increasing the depth of focus and depth of field, so that these patients can increase their vision by closing their eyes. So this is a common finding in patients with myopia and also with patients with astigmatism. The patient have athenopic symptoms, so they have ocular athenia, or they have only tired globe. This is because of that they are always in a state of constant strain to try to see the distant image, but they cannot see. They have vitreous degenerations, and this vitreous degenerations will lead to vitreous floaters, or what's called muscovitans. They also complain from night blindness, and they may have a divergent squint because they don't use their accommodation. So that these patients don't use their accommodation, so the eye don't stimulate the near reflex, which has convergence, so that the eye tend to be divergent. For the signs that they have large eyeballs, they may have large cornea, deep anterior chamber, large pupil and slightly reacting, and the fundus examination will show some changes only in case of pathological myopia, like what's called myopic crescent, due to stretch of the retina over the leaving only bare sclera. We have what's called laquer cracks, like here, these cracks, and we have the subretinal neovascularization can also occur, like here, subretinal hemorrhage, and this hemorrhage, when it heals, it leaves dark pigmented scars called the Fox spots, and there will be a bulge of the posterior pole that's called the posterior staphyloma. These are the degenerative changes that occur in case of the myopia, or only the degenerative myopia. The complications of the myopia are mainly that it can cause macular hemorrhage, as we said, that will heal by Fox spot. It can cause retinal tears and detachment, vitreous hemorrhage, choroidal hemorrhage, complicated cataract, nuclear sclerosis, and primary open-angle glaucoma. So these are some clinical information that are beyond the scope of the basic science test, but just for your information. Here we come to the core of the myopia. So, or what concerns us more is how to correct the myopia, or how to optically correct the myopia. So optical principle of any refractive error is the main part of any refractive error, because this is what will be more concerning in the context of a basic science and optics exam. If we have a patient that has myopia, and this myopia is uncorrected, meaning that we don't put glasses or contact lens in front of his eyes, what will be the retinal image size? The retinal image size in such condition will be larger than the emmetropia. So if we have parallel rays that will now will come to a focus, this focus in front of the retina, and this should be making an image size like this. However, in case of myopia, the retinal image size should be larger. So if the image size in the myopia will be, or emmetropia will be, just a point or a small or a very small image size. But if the patient has myopia, then the image size, or since the eye globe expand, the light rays will diverge after making a focus, leading to spreading over large area of the retina. So again, in uncorrected myopia, the image size is larger than the emmetropia. So the parallel rays will come to a focus in front of the retina, like here. So this will be the emmetropic eye. And will be the image, or the will be the image in front of the eye, or this will be the image in case of emmetropic eye. So if you have a large eye, this image will form an area of circle of confusion. So this will be a large image, larger than the emmetropia, but of larger size and blurry. It will not be clear. So the retinal image size is larger in uncorrected myopia than in emmetropia. This is very important to stress on, because they will have some variations later on, as we will see later. So the retinal image size, again, larger in uncorrected myopia than in emmetropia, and the image will be blurred and not focused. What will be the changes in angle alpha? As we said, the angle alpha will decrease and even become negative. So this will lead to apparent convergent squint. As you can see here, the eye is enlarging, and this will lead to decreasing the angle between the visual axis and the optical axis. So in the myopia, the axis here, this is the optical axis, and this is the visual axis. So this will be the temporal and the nasal. So in case of, this is the emmetropia, and this is the myopia. So in myopia, there will be a small angle between the visual axis and the optical axis, and even it can, with larger myopia, this can be the visual axis. So it will be more on the nasal side, so it will lead to apparent convergent squint. So this is not a true squint, it is just apparent due to shifting of the visual axis. However, the true squint that can occur in case of myopia will be a true divergent squint. This is very important in the exam. And why does the true divergent squint occur? This is because there is a relation between convergence and accommodation. So there we have what is called the near reflex. If we place a near target in front of the eye and we cannot see it clearly, we tend to accommodate. So when we accommodate, we increase the power of the lens, and this will in return cause both eyes to turn inside. Both sides will cause convergence. And since the myopic eyes doesn't have to accommodate because they are powerful, they can see the near targets clearly, so that they don't converge. And since they don't converge, they tend to diverge. So the convergence is less in myopia, and this will lead to true divergent squint. So it is not uncommon to find people who have high errors of myopia to have true divergent squint because of lack of use of accommodation and convergence. We have types of myopia that are called the true myopia, like simple and malignant, that we have just discussed. The malignant is another form or another term for the degenerative. And we have a false myopia. Sometimes they can called as a peripheral myopia. So this is not like due to actual increase of the refractive power of the eye or refractive index of the eye or increasing the axial length. This is just excess accumulation. Patient who have a ciliary muscle spasm. So the ciliary muscle is the one responsible for increasing the power of the lens or accommodation. So if we have excess accommodation due to ciliary muscle spasm, this will lead to increasing the refractive power of the eye, leading to myopic shift. So this can occur as in case of pilocarpine therapy. Patients who have pilocarpine, which is a miotic used for purpose of treatment of the angular glaucoma, can cause one of that can due to ciliary muscle spasm. And this ciliary muscle spasm will lead to inflammation causing myopia. So after knowing the principles of myopia, know what are the optical principles of myopia correction. So we have no problem, which is a myopia, which leads the image on the retina. So how can we correct it? We correct it some things. So the first one is called the far point. The far point, or the other term, is called the punctum remotum, less than infinity, which is in front of the eye. So what is the punctum remotum? A punctum remotum is the area or is a point in which if we have a parallel rays coming from the F or F2 of the eye is present over the retina, so this light through the refracting surface of the eye, they will emerge parallel. Since they are emerging parallel, the punctum remotum will be said that it is now is at the infinity. So the punctum remotum is the area or is the point of intersection of light rays that are coming from the eye. So if we have an emmetropia, normally refracting eye with the with F2 over the retina, and this light rays will come through, will diverge from this F, passing through this refracting material or refracting medium of the cornea and the lens. This divergent rays will be made parallel by this cornea and the lens. And now these points will be will not come to a focus, but they will come to the punctum remotum. So light rays emerging from a point on the retina will emerge convergent, so that they will meet in front of the eye at the far point. So the light rays, the light rays will be emerging parallel again, as we said, as we can see it. Okay. If we have myopia, what will be the condition here? If we have a myopia, so that the light rays will be coming from the F or coming from the F2 of the eye, which is present on the retina. And since the eye is very powerful, so it has a very powerful refractive surface, or even if it is large in size, so there will be increasing axial length, the refracting material or the axial length of the eye will make the light rays emerge from the eye to be convergent. So the light rays in case of myopia will be convergent to form a point. This point again is called the punctum remotum. So again, if we have, in case of myopia, we have a large eye or we have a powerful eye with large refracting or powerful refracting surface or large refractive index, and we have a point from this eye that are emerging light or reflecting light, this light will not pass or will not emerge from the eye parallel, but it will emerge from the eye to converge into a focus. This focus is present in front of the eye, that is called punctum remotum. So how to correct this ametropia, or how to correct this myopia? So ametropia meaning that if the patient has any refractive error, this is called ametropia. So how to correct any ametropia? It is by location, to locate or to know where is the far point or where is the punctum remotum, and place a lens which the focal point coincide with the far point of this eye. As simple as this. Let's see an example. If we have a myopia, like here, the f2 is projecting light rays that will come through the refracting surfaces of the eye, and now they are very powerful, so they will emerge convergent, making a point called the punctum remotum in front of the eye. So how can we correct the myopia of this eye? By placing a lens. This lens will change the punctum remotum from this point to infinity, like the emmetropic eye, provided that the focal length of this lens will be coinciding with the punctum remotum. So the f2 here will be coinciding with the punctum remotum. So what lens to choose? This will depend. If we have a myopia, so this eye has more convergent power, so we need the light rays to be divergent. And what is the optimum refracting surface to diverge light rays? It will be the minus lens. So we put a concave lens in front of the myopic eye that has a focal length. This focal length has the same value of the punctum remotum of this eye. So we use a concave lens with its focal point coinciding with the far point of the myopic eye. This lens will deviate the incident parallel rays so that it will appear divergent from. Therefore, the light will be brought to a focus by the light on the retina. So here we can assume that if we have a minus lens placed in front of the myopic eye, what will happen? Here we can see that the parallel rays entering inside the myopic eye will come to a focus in front of the retina. However, if we put a minus lens in front of the myopic eye, the parallel rays will fall into the minus lens, leading to divergence. Since these light rays are divergent, they will enter into the optical system of the eye, which is either powerful or large or have high axial length, so that this lens or this powerful eye will make the light rays, this divergent light rays, to come to a focus just sharp and crisp over the retina. So is it clear up till now? So Dr. Hager say that the sound is metallic or robotic. This can be due to poor connection. So is it only Dr. Hager, or all of you can see that the voice is metallic? So if it is a problem at your connection, you will hear the recording clearly, or you will hear the recording with normal voice. But if it is a problem at my connection, then the record will be of the same quality as well. Also, I guess that we need to deal with this, because this is the drawbacks of using these online classes, that the internet connection is not always fixed all the time, and it can the quality can become sometimes good, sometimes poor. Yes, we wish so. Okay, so now we need to know how to calculate the power of the correcting lens. We said the principle, so let's have the calculations. We said that the power of any lens will be the power will be equal 1 divided by the focal length. So this we said that this is the #1 rule in optics. the power of any refracting surface equals 1 divided by the focal length of this surface. So if we put a lens in front of the eye, so the power of this lens will be equal 1 divided by the focal length of this lens. This is provided that the correcting lens is placed at the principal plane of the eye. Please focus very much. If we wanted to correct the eye or to correct a myopic eye or an eye with a refractive error, ideally speaking, we should place the refracting or the correcting lens at the principal plane of the eye. But so this is the principal plane of the eye, which will be inside the eye, which is about 2 millimeters behind the anterior corneal surface. But practically speaking, we cannot do this, because when we are placing a spectacle or when placing glasses, we are placing in front of the eye. So here we placing the spectacle, or the spectacle will be in front of the eye. So what shall we do? If we have a correcting lens that is present in the spectacle plane, the spectacle plane itself is 13 millimeters in front of the principal plane of the eye. So here we have, this is the principal plane, and this is the F1, and here we have the principal plane. From the distance between the principal plane to the F1 is 17 millimeters, and the distance between the anterior corneal surface to the F1 is 15 millimeters, and the distance between the principal plane to the lens plane, or the plane that in the trial lens frame, or the glasses placed in front of the eye, will be only 13 millimeters. So this principal plane, or this distance, should be compensated in the formula. So the power of the correcting lens can be calculated by this formula, which is the power of the correcting lens will be equal 1 divided by f, which is the focal length of the lens, minus the back vertex distance. So the back vertex distance is 13 millimeters, which is the plane at which the glasses is put on. And in such a condition, in case of myopia, or in case of using a corrective lens in front of the eye, we use the back vertex distance in the negative form, because when we are putting the lens here, we moved from the principal plane to the left side, which will be against the direction of light rays. And that's why it will be present, or it is, as we said, in the Dunder's reduced eye, that it will be minus 17 millimeters. Again, the 13 millimeters, or the back vertex distance, will be calculated by in the minus value, so it will be minus 13 millimeters. So again, if we put a lens in front of the eye and we want to know the power of this lens, we should calculate it by this formula. The power will be equal 1 divided by f, which is the power of the lens, minus the back vertex distance, which will be 13 millimeter in minus, because we are not putting the lens in front in the principal plane, but we are putting it in the spectacle plane. So let's have an example. If a patient who has myopia, this myopia is minus 4 diopters, so the power, or the f, equals 1 divided by 4, so it will be minus 0.25 millimeter. So this will be the actual focal length of the lens when it is placed in the principal plane. And as we all know, we always use the metric form of the measurements, not the millimeter. So since we put it in the spectacle plane, we should take into consideration the back vertex distance, which is minus 13 millimeters, or minus 0.013 millimeters. So the power of the correcting spectacle, if a patient has myopia minus 4, will be equal 1 divided by f minus d. So 1 over minus 0.25, because the patient is putting a minus lens. So the focal length will be in the minus form, minus 0.013, so it will be equal minus 4.25 diopters. So as you can see that although that the patient has minus 4 diopters, when we are correcting him, we are putting minus 4.25 diopters because we are using a lens present in the spectacle plane, not in the principal plane. So if we are using a minus lens for correction of myopia, the minus glasses will be actually more than the actual error that the patient has. So again, the power of the correcting concave lens in myopia held at the spectacle position of 13 millimeters are more than the refractive error of the eye. I hope that this concept is clear to you now. But what happens if we put a contact lens? What happens if we put a contact lens? If we put a contact lens, then we should change to the contact lens power. And the form or the formula used for calculation of the power of the correcting contact lens will be the dioptric power of the contact lens will be equal to the dioptric power of the S. What is the S here? It is a spectacle. So we calculate the power of the contact lens based on the power of the correcting spectacle. I hope that this is clear. So the dioptric power of the contact lens will be equal the dioptric power of the spectacle divided over 1 minus d, or the back vertex distance, multiplied by the power of the spectacle. And here we have the back vertex distance, which is positive. And why it is positive here? This is because when we are changing from the glasses formula to the contact lens formula, so the contact lens is present over the cornea. So when we are changing from the spectacle to the contact lens, and we are calculating the power based on the on the spectacle, so we are moving from the left to right. So it will be with the same direction of light rays from left to right. That's why the back vertex distance here is by the positive value. So in the first example, when we are changing or when we are using the spectacle back vertex distance by calculation from the principal plane, we were moving from the right to left. But when we are calculating the contact lens power, we are using or we are based on the power of the spectacle and the spectacle position. So we are moving now from the left to right, which will be the normal direction of light rays. That's why the back vertex distance will be by positive. So let's have the example. Yes, this should be in meter. Thank you, Dr. Doha, for your notice. It is 0.03 meter, not millimeter. So when we are using the power of the correcting lens, then we have this formula to calculate. So if we have a myopia of minus 10 diopters, then the power of the contact lens or the correcting contact lens will be minus 10 diopters divided by 1 minus the positive value of the back vertex distance multiplied by the power of the correcting spectacle, which is minus 10. So the net result of this formula will be minus 8.85, which is less than the actual power. So less than in case of contact lens correction of myopia, the actual power is less than the actual power of the eye. So if the correcting lens is placed at the f1 of the eye, the retinal image size is unchanged. This has been repeated more than once. If we have a correcting lens we said that in case of uncorrected myopia, the retinal image size is larger than the emmetropia. But what happens if we correct it? If we correct the myopia and placing a spectacle that is present at the f1 of the eye, which is 15 millimeter in front of the anterior corneal surface, the retinal image size is unchanged. And if we place the lens further than the f1, the retinal image size will decrease. And if we place the lens nearer than the f1, the retinal image size will increase. That's why if we have a myopia or a patient with myopia and they want to have more magnifying effect, they want to enlarge the retinal image size, they tend to push their glasses toward their eyes, so they have more magnified effect, because the correcting lens, when it is more closer to the eye, more close than the f1, the retinal image size will increase. I hope that this is clear.